All right, let's get started for today. Joshua, you can turn on your camera so I can see you. You know, I like to see everybody's face, so thank you so much. Appreciate it. You know, I actually look at your faces during the lecture, and I'm seeing if you're there or not, or if you're understanding, shaking your heads. So actually, it does help me, continue or maybe something else to say, okay, about the same subject. So it's nice to see your faces. Excuse me. Sorry, my voice is still crazy. What I have determined is my rheumatoid arthritis. I missed an infusion about 2 weeks ago. And believe it or not, in your voice box is a joint and it's swollen and inflamed. And that's what's causing my voice to sound like I have a scratchy or I'm sick. I'm not. But I go tomorrow and get the infusion. Finally figured it out. They never called me. So partly my fault, but it'll be done tomorrow. So I hope with that and a little bit of steroids will be good. So week 5, this is a very hard week. This is cardiac respiratory, and we're going to show how they work together. And I'm going to try to make you think of it as a garden hose. If you get a kink, where does the water go or where does the blood go? And if you think of it that way, you'll be able to understand the heart and the lungs a lot better, okay? There is a quiz at the end of the class today. It is 5 respiratory and it's 5 on cardiac, so it's equally paced there. You have 2 case studies that open today, which is cystic fibrosis and congenital heart disease. So they are due, I believe, next week, but they do open a week early, and then they stay open a week.
What the fuck?
Discussion question 4 is also due. So remember, by Wednesday night, get your initial posts in, and then the 2 peers by Sunday. So last week you did your exam 1. Did you all think it was a fair exam, that everything that you saw on there was covered? Okay. Anybody who wants to go over the exam, it might be you have 1 question wrong, or you have 20 questions wrong. I'll go over it with you because you don't want to go saying, well, I got 1 question wrong, and gee, I wish I knew what it was. I don't mind. That was me as a student in my graduate classes. I want to know what I got wrong. It's just one of those things. We had 100 in all of the classes. So congratulations to that person. I'm not mentioning names. All right. So what are we going to do today? Like we normally do. We're going to do a PowerPoint, and then we are going to be doing the Kahoots. So remember, if you have any questions, it's going to get rough. So I'm not explaining something that you understand, stop me, because I'm sure somebody else doesn't understand. Now, cardiac is probably the strongest part of my nursing knowledge. I did 10 years at a congenital heart unit, the congenital ICU. It's a program that I opened up at Nicholas Children's Hospital when it opened back in 1995. And I worked there for 10 years. And I built the program with an internationally known physician, Dr. Redmond Burke, who is amazing. And I helped build that program. And I can see a heart in my head. I can see it beating. I can see where blood flows. So I'm going to try to make it that simple for you. As long as you know basic anatomy. So if this is a hint, you don't know basic anatomy, go look the way a drop of blood flows. And I'll go over it once in this PowerPoint as we keep going. Well, we're going to start out now with respiratory, because if you don't have oxygen, nothing else matters, right? We know in questions, oxygenation.
Evelyn said that she's having trouble hearing. She sent you a message.
Okay, could be her computer if everybody else hears me. Does everybody else hear me?
Yes.
I mean, it might be a little squeaky, but it's still, you can hear me, correct? Okay. Tell Evelyn, like one of the other students, they came in on their phone to hear me. Okay. That would be a suggestion. So another student already did that now. Okay, let's look at the lungs and let's look at infections. There's two types. There's that upper respiratory, which is your nose, your pharynx. It's all of that mucus junk up in your upper airway. And then there's that lower airway, which is going to be like your pneumonias, right? That's going to be, could be cystic fibrosis with a bunch of mucus down there, which is collecting an infection. So just think of it, is it at the upper? Can I clear it, that noise, or is it lower? Asthma be a lower one. Now, most of our upper respiratory infections are viruses. That's why if you take your children to the doctor and you take them to the doctor and they've had a fever for, since last night, it's 103, and you're like, we need to give antibiotics. And they say, no, you've got a cough, you've got nasal mucus, you've got a fever. All you're going to do is treat the fever with acetaminophen and ibuprofen and give plenty of fluids and rest. Well, on the third day, they still have a fever. That's when you bring them in, and then they'll put you on antibiotics, because usually those fevers and viruses are not going to last that long. And I'll give you a hint, you as parents. Those high numbers are usually viruses. Usually, and this is my career I've seen, this is not in a book, this is just the knowledge of Professor Bogart, 101 to 102 are usually bacterial, especially pneumonias. I've never seen them higher and usually not lower. It's right in that little 101, 102. Now, those bacterial infections could be a little bit of anything. I mean, staph is always in our nose, but all of a sudden it goes crazy and then it, requires antibiotics. Now, let's go back and look at those infants. So when babies are born, they've got mommy's, immune system. They got mommy's hemoglobin hematocrit, and we know it just starts to go away, and it's not as strong. So what happens? Well, for the first 3 months, an infant shouldn't really get sick with viral diseases because that's mom's antibodies. And if they do, we treat that very quickly, and we we're very concerned. Now, after that, 3 to 6 months, that's when the immune system isn't as strong. And now we're going to be catching those viruses by, being out in public, being around people. Babies like to put everything in their mouth, take them to the grocery cart. If you don't got one of those beautiful little cloth things that cover everything, they're sucking on the handlebars. And we know this is what kids do. They're catching these infections. Now, the only good thing about getting sick is what is the body doing? It is now building immune system so that they don't catch that virus again, and their body's stronger. So next time they catch it, it's not going to be as bad. Now, I've told you about toddlers. All they do is they swap spit all day long in daycare, right? One toy to another toy, from this kid's mouth to that kid's mouth. And now they are exchanging their germs. It is normal. It's what they do. It's a lot of viral infections. You'll see viral in earaches usually. When, of course, earaches we take as a bacteria, but virals. So again, Tylenol, Motrin, plenty of fluids. Now, again, they're building their immune system, getting ready for school. By the time they get to school, now they're just more into the bacterial infections. So those virals aren't going to be as prevalent as they used to be when they were younger. And of course, your immunity increases with age because you've gotten all those immunizations too. 2 months, 4 months, 6 months, 12 months, 15 months, 2 years. I mean, they're just giving them, because we don't want them to get those really bad diseases. Viruses we can treat, little bacterial infections like ears we can treat, but things like pertussis and diphtheria, we don't want any child to get. Now, kids, they've got these little short, wide open tubes. They've got these eustachian tubes where all the mucus from all of that nasal congestion goes right up into the ears. And that's why they get a lot of ear infections, because everything is shorter, open and it moves quickly. And if there's a lot of mucus here and over there doesn't have any, it's going to push it out there because there's room to go. So it goes into the ears. Now, what does a kid look like? Well, you can say if a kid has a fever and is not playing, something's wrong. Another thing is they have a fever, they're not eating. Now, usually kids, you put their favorite foods in front of them, they're going to eat. You know, us adults, when we're sick, if somebody puts our favorite food in front of us, we're going to eat it, even if we don't want it, right? Kids don't. They'll sit in the corner, they're not going to play, and you're going to see them feeling horrible. Now, maybe they'll vomit, not all the time, but this is what we will see. Now, why do we give Tylenol and Motrin to children? There's only one reason. It's not to prevent bad things like seizures, like you might think, because those are rare for those regular fevers. It's because they don't feel good. They ache, they pain, they don't feel good. And children are miraculous. That fever comes down, they're running around, and they're drinking and they're eating, which is what you want, right? So that's why we give acetaminophen, ibuprofen. Now, respiratory, what is our goal? Got all of this mucus, you've got this cough going on. What do you want? Well, you want them to breathe easier. You want them to be able to rest because they can breathe. You don't want that infection to go around the family or around the school if they are in school or daycare. We want to get that temperature down because then we can promote that hydration and nutrition, okay? And these kids just want to hug when they have a fever and give them their medicine and, you know, they'll feel better. And you'd be surprised telling even the younger kids, one-year-old, this is your medicine, it's going to make you feel better. You know, it's going to get that fever down. You're going to have your juice, whatever your favorite juice is. And we know at 1 year they're going to be, I want apple juice or I want orange juice. They're going to tell you what they want and by whether they accept it or not. Now, otitis media, as I said, short, wide open, mucus goes in there. And the one thing I could tell you about otitis media, it's a middle ear infection. And that drum gets swollen and these kids hurt. They hurt. Number one nursing priority with otitis media is to give them something for pain before we even have the doctor see them for treating them. Get rid of that pain. You're still going to see the bulging eardrum. You don't have to show pain or show a fever for a nurse or a doctor to believe that there's a pain in the ear because we can see it, okay? So we look in the ear, we see what's going on, and we're going to give them something for pain, and we're going to describe that to the parents too, teach the parents. And actually, I like and I recommend, I think ibuprofen has an anti-inflammatory in it, and I think it works better than acetaminophen, although they both work just as well. But acetaminophen lasts 4 hours, ibuprofen lasts for 6. So if I'm putting a kid to sleep, I'm like, Mom, you want to sleep longer? Give the ibuprofen before they go to bedtime, and then you will sleep longer with the child. So those are some hints that I've given parents along the way. Now, you're going to get antibiotics. Make sure they take it all, not until when the ear pain goes away, not until when the fever goes away. They need to take the whole dose because if they don't, it could reoccur. Now, a reoccurrence of ear infections, 3, 4, 5 a year, and some kids get them like that, may require a surgical intervention. That surgical intervention is usually putting tubes in the ears, which drains the mucus, so that pain is not going to be there. So if we're trying to prevent surgery, it's making sure they take all those antibiotics. Another trick I've taught them is I put these younger kids, not the babies, but younger kids, you know, your toddlers, tell them to sleep on a pillow, have their head up. Because believe it or not, when they lay flat, it pulls the ears back and it hurts them, especially for the first day or two. So these are my tricks. It isn't in a book. It isn't a quiz. I'm just telling you, those are things that I've taught and parents have come back to tell me you were right and thank you. Because of course they're going to come back for something else. Now, infectious mononucleosis presents with extreme fatigue, fever and sore throat and aches and pains everywhere with swollen lymph nodes. Now, I want to tell you a story about the kissing disease, right? That's what you know it as. This is, as I said, it's a sore throat, fever, and just general aches and pains like flu-like symptoms with these swollen lymph nodes. Now, I had a little boy, I believe he was 9 years old, came in on a Saturday. He had already gone to the doctor on Monday. They told him it was a virus. It wasn't strep throat. It wasn't the flu. So they said, you know, just give some ibuprofen and acetaminophen and he should feel better. Well, 3 days later, the kid still didn't feel better. So the doctor put him on antibiotics. Well, now it's, 6 days after that. Antibiotics aren't working. This kid still feels horrible, still tired, still with fever, sore throat. So what do? Well, we're going to draw blood if they come to urgent care or ER at that point. So he's already tried antibiotics, already said it's the viral, already been through that. So we draw blood and we're going to do a CBC. What are we looking at? Well, we want to look at the white count. Is it a bacteria, right? Well, their white counts on infectious mononucleosis are going to be normal because it's a virus. But we're also going to do something called a monospot test. The monospot test says, yes, it is infectious mononucleosis. Then we are going to do some heavy hit teaching about mononucleosis. Okay, it's still treating them as a virus. Acetaminophen, ibuprofen for fever, for pain, plenty of rest, lots of liquids, but we are going to emphasize no PE, no sports for at least 3 weeks until they are cleared by their physician. No contact for sure. Teaching the brothers and sisters no rolling around on the floor is what kids do, right? I had 6 brothers. They always had me on the floor, rolling me around, pinning me down, trying to tickle me and do crazy things, right? But my belly might have been touched. As you see, there's a swollen liver or a spleen or both. All right, we gave these instructions to the child. We gave these instructions to the father who came. I gave them and the physician also gave them. And we gave written information. So this is 3 forms of teaching we did. 1 week later, I am the primary trauma nurse for any trauma that would come into the ER that day. We get a call that we had this kid, 9-year-old boy, fell off of a trike, a 3-wheeler out in the Everglades and fell and was unconscious and they were bringing him in. This was my infectious mononucleosis kid from the week before. He was on the back of a trike with his brother, fell off, hit his belly, his spleen exploded, and he was dead on arrival. Now, have I made the point how serious infectious mononucleosis is and teaching no contact sports? Why was he at 1 week post mono out on a trike where he could fall off and he could, hurt himself? Let me tell you, I am still upset about it. And the physician that took care of him that day was also there, and he was also devastated. But there was nothing more we could have done. We did everything right. And I feel horrible for those parents today still. Okay, croup. This is barking like a seal, right? This is that really heavy, you cannot mistake this cough. You can hear it everywhere. It's inspiratory stridor. So inspiratory stridor. Now remember that because asthma is expiratory, okay? So inspiratory is croup. Now croup affects the larynx, the trachea, and the bronchus. Now it's a virus. It's really benign, but If we don't treat it with a steroid to decrease that inflammation, it can turn into epiglottitis, which is an extremely serious high-level emergency. And we're going to go into that in a second. Now, before it gets to epiglottitis, you've been crouping. Now you've got tracheal bronchitis. So you've got the cough from the trachea swollen, and the bronchus is now all swollen. So now you've got this dry, hacking, non-productive cough that worsens at night. So bronchitis worsens at night. It's that non-productive. Again, it is usually a virus. So we treat it for the fever, and they're usually low grade, Tylenol and Motrin. And we're going to be given hopefully some humidity in the room. The parents put the humidifier up, and usually we'll give some sort of cough suppressant to try to keep that cough down, because at night, again, that cough worsens at night when they're trying to sleep, right? So hopefully some cough medicine will help them rest. So then we're into that acute laryngotracheal bronchitis. The whole thing is all inflamed. Again, we've got, croup. This is really another name for it, laryngotracheal bronchitis. So now it's all the effect. And this is what we're going to see with that. Again, this is all inspiratory when we talk all this upper airway stuff. You're going to be retracting, again, that barking seal-like cough. And then as it goes, it's going to get worse and worse. So the distress is going on. You can't breathe. You're not getting oxygen. You're going to see a kid who's restless, who's air hungry, barking, coughing, and it's going to lead to respiratory failure or acute epiglottitis. Now, what's an epiglottis? That is the leaf-like structure that covers the trachea when you swallow food down your esophagus. So food doesn't go in your lungs. Well, this epiglottis says, I'm just going to swell up and cover everything. And now you can't have a hole to breathe in. So you're trying to find some air to get in, but this is covering it back there and you can't breathe. So you will see this child usually in that bent over tripod position that you see in the COPDers of old people. They'll be bent over, trying to get that throat in a way where there's a little piece of air going in there. They're not able to swallow anything, so they're just drooling like crazy. Their voice is muffled because it can't talk like that because it's all swollen. So anytime it's muffled like that. That's really what it sounds like, believe it or not. And again, inspiratory stridor, again, you're going hypoxic, you're retracting. What is our job as a nurse? Well, if we suspect epiglottitis, you don't look in that mouth. Only a person who can intubate is going to look there. And as a nurse, your priority is to get an intubation or a tracheostomy tray at that bedside, or put them in the trauma room where all that stuff is already, because it might end up trying to get an airway quick. And those are the two ways you can. How do we treat epiglottitis? Well, it's a virus. It's swelling. We're going to be giving an aerosol, epinephrine aerosol, and the epinephrine mist goes directly into that throat, into the epiglottis, and tries to decrease it. We're also going to give IV steroids. This kid cannot eat or drink. He's in acute respiratory distress. Your goal is to try to get an airway somehow, some way, and in between getting them that steroid to decrease the swelling and that epinephrine, given in the aerosol. And sometimes they give epi a little sub-Q shot just to try to get that. It's almost like an anaphylactic airway gone. I can't breathe. I mean, it's really severe. It's horrible to watch. And of course, after this is done, as I said, you can't eat or drink. This child will have to have IV until we get that airway open enough so that they can maintain their own hydration. Now, another thing we've heard about is RSV, right? Little babies, you hear RSV. Another word for it is called bronchiolitis. So now you know it's the bronchus are inflamed. This is something that usually happens at the change of weather season, like winter, early spring. And you will see a child with a little temperature, like less than 101, like in the hundreds somewhere, just a fever. They'll be full of mucus, full of mucus. And you hear this loose cough coming up. And these children have a hard time. Well, think about an infant. That's who affects it the worst, that really need the most struggle with it. Me or you, this is a common cold. You blow your nose, right? And then you can eat and drink. Well, an infant, they don't know how to blow their nose. So we need to clear their airway, because to suck, swallow, and breathe is a lot for an infant. So you know that their obligatory nose breathers is full of mucus. They don't know how to breathe through their mouth. How are they going to eat, right? That's the big deal. How am I going to eat? Now, there are some newborns, we've mentioned, well, today we're going to mention the congenital heart child. Well, that child already has a problem with his heart. We don't want to put any more strain on it. We do not want them to get RSV. So there's something called Synagist. It's also called palivizumab. It is preventative. It's given once a month for those immunosuppressed children or premature infants, okay? And it's usually through fall through early spring if you have those seasons going on. I mean, I live in, Miami. It's a little different down here, but still, we give it monthly, and it does prevent RSV. A normal, healthy newborn child, as I said, can get RSV. So when we're talking about that, how do we take care of it? Well, you're going to suction the nose out. Maybe give a saline aerosol to loosen it up, to suction it out before feedings. And then, of course, we're going to take our time slowly feeding this child, okay? Okay, tonsillectomies. Kids get those, right? The tonsils are big, it's in the back of the throat. They keep getting, throat, sore throats, pharyngitis. So one of the things children do is they'll get tonsillectomies. Usually they do tonsils, adenoids, and sometimes they put tubes in at the same time. They do all three. It's a 3-for-1 deal, I guess. But how do we treat, or how do we teach these parents to take care of these children? Well, post-operatively, let's say they want something to drink. This is the first time they're asking. Only give a couple ice chips. Let it melt. The coolness will feel great. And then they're not going to choke or gag on a fluid, okay? So first thing you give them is only ice chips. Now, as they keep going on, you can increase their diet. Don't give anything red, because we don't know if it was blood or not. And we do know sometimes kids do bleed post-tonsillectomy. And I'll have a story once I go through this, of course. Now, no irritating or highly seasoned foods, like no citrus, no orange juice, that will burn. You can, brush your teeth, but don't go crazy, because it can disturb the scabs, because they're literally just scabs. There's no suture lines. There's scabs where they removed the tonsils and the adenoids back there. So just easy, no like trying to type thing and get things up, okay? Because you will cause the scab to come off and they can bleed. Avoid coughing or clearing the throat, putting things in the mouth. And look, kids, straws. So if they have a drink, don't put a straw in it, because it's extra pressure on the throat, all right? Using something for pain. Now, years ago, they'd send them home on some hydrocodone liquids, but they found out kids were actually overdosing on it. So today, we know just acetaminophen is good for these children. And we just give it every 4 hours. And then we put an ice collar on the neck, and that does help with the pain also. Have them sitting up. And as the kids are older, a couple days post-op, they get these ear pains. But if they chew gum, it helps relieve the pressure. It's a trick for those older children. Now, if you have, postoperatively, there's blood in there, it's not going to smell good. But if it continues on and after 2 weeks, there's probably an infection, especially if you have a fever, then you should get to the doctor. But post-tonsillectomy, kids should be up and moving after they've been seen post-operative visit within 2 weeks. They can be in the normal activities. Pneumonias. Well, pneumonias could be due to almost anything. You can inhale powder, right? You can inhale your food, aspiration pneumonia, or it could be some sort of bacteria that's caused it. Now, as I said, there's bacterial, there's viral, mycoplasma, pneumococcal, and that's why we have a pneumococcal vaccine now. And even the infants will be getting that to prevent, because it's a harder disease to take care of. Mycoplasma is usually your older kids, those kindergarten kids. But, young infants can get, some sort of pneumonia. So we treat it with antibiotics if it's the bacterial, and we just Tylenol, Motrin for those kids. Now, pertussis. Pertussis was completely wiped out, like polio. We didn't have it. Well, now because of some children not being immunized, some parents don't believe in immunizations. So some of these diseases have come back. Pertussis, it was about 6 years ago now. I was working in the ER and we got a notification that the next the county up had 3 cases of pertussis that came into their ER. What is that important for us to understand? Well, pertussis presents like a respiratory barking, almost like croupy looking, right? But it's extremely contagious. And it is dangerous and requires a really broad treatment. These are children like the chickenpox kids. They need to be put into a reverse flow room so that the air doesn't go out into the whole hospital. And as nurses, put on a mask, an N95. Don't mess with it because it is something that can be harmful, especially if this kid exposed, to young infants. We know that these kids come to urgent care, they come into ER. I mean, you try to put the infants in a corner by themselves, but some kids go where they want to, and it could spread it. And those infants are at high risk for a lot of things to happen. There is a vaccine for it, and that's why we always recommend it. Now, foreign body aspiration. What do kids do all the time? Put everything in their mouth, right? It's all oral, it's self-soothing. Now, they like coins for some reason. And the crazy part is, it's not a dime or a penny, it's always the quarter they swallow. And that's a quarter stuck right there, okay? These kids come in, they're not able to swallow, and they're drooling because it's there. If they are talking or breathing, you're good. It means it's gone down and it's in the esophagus. Now, there's all sorts of other things. They put crayons in the nose, the ears. We talked hot dogs and little pieces of hot dogs. They can aspirate these things. I saw a French fry get inhaled into a lung. Couldn't get this kid breathing, ended up on ECMO, and the kid 3 days later died on a French fry. So, and it was a 3-year-old. So making sure things are at small pieces. The things I've seen, I'm glad I've seen them after my kids were grown up, because I'd be absolutely paranoid all the time. And I actually was with my grandson, but they do everything in their mouth. Now, let me tell you how they take this out today. Years ago, these kids, you'd start an IV, send them up to the OR, give them some sedation. They do a bronchoscopy, go down with clips, grab it, and pull it out. Today, what we do is we take them in the ER and we sit them on the surgeon's lap with the parents, whoever's there, I'm usually coaching them on, and they take a Foley catheter and put it down the mouth below the coin, blow up the Foley balloon, right? So now we've got a big wide area. Now, the kid's going to lean forward, and then the surgeon's going to say cough, and he pulls it out. They usually vomit with mucus, and the coin falls on the floor, and I'm yelling, I'm going to get the coin first. If I get it first, it's mine. I've taken this kid off what just happened, and he's on the floor. No, it's my quarter. And we know he's fine and he's breathing, don't we? So I use this distraction method and it works. Post doing this, sometimes it might take 2 times. I've never seen it more than 2. They don't have to stay in the hospital. They need to stay for a little while to make sure their airway's okay, like 2 more hours. And then, of course, we tell the kid all about we don't put things in our mouth, et cetera, and they go home. But I'm telling you, most of the time it's a quarter. Now, the other pneumonia we're talking about is aspiration. Years ago, we used to love Johnson & Johnson baby powder. The smell was so wonderful. But now that powder in the air, they inhale it, we could hurt their lungs. So we shouldn't be using powder on our infants, young children, any children anymore, even adults. It goes into our lungs, okay? The other thing we're going to worry about is, you clean the bathroom, you have bleach and, all of this chemicals. Kids shouldn't be in there inhaling these. Have you ever cleaned a bathtub with bleach and then you feel sort of, you're breathing bad? Well, kids get that too. It's like, it's an aspiration pneumonia of those type of solvents, and it can get quite, hairy even on adults. So keep the kids out of there during that. And another thing is feeding. A lot of kids, they're always refluxing. They're, vomiting a little bit. And remember, they can aspirate. So we need to do everything we can to prevent feeding from causing aspirations. They need to be burped well. They need to sit up after feeds. We don't need to overfeed our children because that's going to cause them to aspirate and to vomit. And we don't want an aspiration pneumonia. Now, I mentioned earlier about cystic fibrosis and mucus in the lungs. Well, cystic fibrosis is twofold. It is mucus in the lungs that the body can't handle. So we have to do all sorts of pulmonary care to keep it loose and keeping it come out. So aggressive chest physiotherapy. The second thing is all about nutrition. They don't produce the amount of enzymes they need to be able to break down the food into a substance that the body can use. So what would you see with cystic fibrosis? Well, as we get to GI, you're going to hear me talk about different things that you'll see if an infant doesn't move their bowels within the first 2 days of life. I mean, usually within the first day, they've already gone 2 or 3 times. With cystic fibrosis, they don't. And they will suspect it could be cystic fibrosis. So what do we do to test for cystic fibrosis? Well, as you see, the symptom is very salty tasting skin. If you were the parent, if you lick this child, you're going to taste salt. Now, as nurses, I would never tell you to lick the child to see if they had salt, but it would be very salty. So we do something called a sweat test, simple. And it's done, and they check the amount of salt that's in the skin, and they get the diagnosis from that. So we know that they have salty skin. We know at birth, that's what you would see. Older on, if we didn't catch it, you'd see a persisting coughing. Sometimes you get phlegm out of there. They're going to have frequent congestion because there's consolidation of this mucus in the lungs. They'll have pneumonia. They'll have bronchitis. They'll be wheezing. They'll be short of breath. The other thing which is very distinctive is because they're not breaking down the food in the small intestines, it's going to be this greasy, nasty, foul-smelling stools. And that sometimes the first thing you go, oh, something's not right here. And then the other thing is they don't have enzymes to digest the food to be able to use them. The body's not getting nutrition. So now it's poor growth or weight growth, no weight gain or minimal weight gain. I mean, that's why, again, why we do height and weight at every visit of every age of children. We want to make sure. Sometimes that's what you're seeing, you know, on the, say, on the 3-month visit or 4-month visit, they haven't gained weight. Well, then you smell the stool. You're like, okay, maybe we missed it, because it is sometimes you don't catch it at birth. So sometimes it's just the height and weight. So again, you do your sweat test, and then how do we treat it? Well, number one, I said absolute aggressive chest physiotherapy. You know, those vests that vibrate it, you know, sometimes they're 4 times a day, you know, with aerosols going, bronchodilators, keeping those lungs open. And then they are in chronic infections in their lungs. I call their lungs petri dishes. They're ripe and ready to grow bacteria. And that bacteria causes that infection, causes pneumonias, which could go to overwhelming sepsis if we don't treat it. So antibiotics are going to be used to prevent. It could be an orally, and we give it in aerosols, you know, a very common gentamicin aerosols for the cystic fibrosis children. We're going to use every medicine we can to make that mucus thinner, easier to cough up. And then we're going to be using whatever device we can to help these kids loosen and clear that mucus up, like that chest vibrator that I was talking about. Now, the other part of it is the inability to absorb nutrients in the small intestines. So we give something called pancreatase, or a pancreatic medicine. There's different names, but pancreatase is usually the one that comes to mind. Now, very clear instructions must be given this medicine. And it's actually one of your NCLEX questions for CF, okay? Do not crush or chew any enteric-coated beads. And we know the cystic fibrosis does have these little beads in some of those capsules. I mean, you could take the capsule and sprinkle it on the food, but you can't crush it. You can't bite it. It needs to be taken down whole. The other thing is there is powdered forms, and younger kids, I mean, an infant, how are they going to take a pill or, you know, a capsule? They can't. So you put it on their food, and then when they're done, make sure you rinse their mouths out. You could just take a warm washcloth, wet washcloth, just water, and clean off, especially if they have teeth, because it will break down the enamel. And the one thing we forget with a lot of medicines, as a child gets bigger, gains weight, gets older, they need bigger doses. It makes sense, but sometimes we forget that. Now, women can have babies, but there's higher risks for so many things with it. So what they say with pregnancies, men and women wanting a child can have one 1 year after a bilateral lung transplant. Men cannot have children until after that bilateral lung transplant. Something to do with the vas deferens and the sperm, it doesn't work, but after they have the lung transplant, it works. How? I'm not into the big technical reasons why, but it's in all the literature that I've read about it. So women can get pregnant, but it's hard to have a normal pregnancy, so they don't recommend it, okay? Men cannot until after that 1 year after bilateral lung transplant. Now, ARDS, acute respiratory distress syndrome, can be due to many different things. One of the things that you see with children a lot is they go into these things, this all has to do with sepsis that goes on. Kids get an infection and they get sick really quick. And it could go into the blood, could go into the lungs, could go anywhere. So sepsis is huge. And if you get ARDS due to sepsis, you are an extremely ill child. Usually these children are with 1 nurse to 1 patient. Instead of in the ICU, usually it's 2 patients to 1 nurse. Yeah, not with this child. And sometimes it's 2 nurses to 1 child because they're that sick. A lot of them end up on that ECMO, which is like a heart-lung machine. which actually nurses run. I actually got certified in doing the ECMO machine, and it literally just takes blood off, goes through a machine, gives it oxygen, and it puts back in. We use this a lot with those near drownings, because their lungs have been so damaged by the hypoxic moment, and because of the water has damaged the lung lining and they can't exchange oxygen and carbon dioxide. Another thing, trauma. If you motor vehicle, right? We know motor vehicles and unintentional traumas are the big thing in children, and they could crush their chest. And adolescents, you're going to see more of the drug overdoses that can cause ARDS. Now, this is a really common picture of a child that's gone through some sort of hypoxic episode. This could be ARDS. It looks more like this is your ECMO machine. All of those wires going everywhere drive me nuts because I like it neat and orderly, but sometimes you can't do anything about it. I'm one of those OCD, everything's got to be neat, orderly in its place. And I can't stand that I can't see where all those things go. I'd have little tie straps everywhere. But, that's me. You don't have to. So what do we do with this ARDS and when a child looks like that? And it could be any age, could be on a bed. This happens just to be an infant. Well, we put these kids, we paralyze, sedate them. And of course, pain medicine with it too. And we let the machines, the ventilator and the ECMO machines work for the child. The ECMO machine takes blood out, oxygenates it, puts it back into the child. And then we're doing respiratory therapy on that child while they're on ECMO to try to get those lungs working. And then we'll decrease the machine's work and let the child work more slowly to see if the kid tolerates it. But mortality rates are very high in this. Now, CPR. Many times we need CPR, right? So knowing CPR is part of our requirements. I just renewed my CPR card and my PALS cards just because I like to keep them up to date. The thing about CPR in a hospital is today, unlike yesteryear, we allow parents to stay with their child. You imagine if a child died and the parent wasn't there, can you imagine how that parent would feel? Like, that parent needs to know that we did everything possible to keep them alive and that we worked very, very hard at it. Now, sometimes there's just not room and they have to be by the door. Now, make sure somebody's letting them know everything that's going on, that they know what's happening. And then after it's over, if they live, make sure they know what their possible outcomes could be. Were they hypoxic too long? Are they going to have brain damage? Do you think they're going to have another cardiac arrest? I mean, be honest with these parents. They're suffering. This is their kid, and it's hard. It's very, very hard. I mean, CPR, we do what the American Heart says. We don't not do anything like that. Although in the hospital, you're going to see variations of the way it's done. It's not going to be 15-2 or 30-2. It's going to be, its own little method there. And you'll see that. You're like, why aren't we doing it the way we're supposed to? Now, asthma. I mean, how many of you have asthma? How many of you have children who have asthma? I mean, it's a very common thing. Now, if you have a child who is a kid who is wheezing, and if they're wheezing, one of the things that you might suspect this child has is asthma. And that should actually be your first thing that you rule out, because asthma is, the lungs are, tight, they're not exchanging, and you want to give that bronchodilator and open it quick. If it's cystic fibrosis, upper respiratory bronchitis, there's other treatments, okay? But asthma, we know we're going to give some steroids, we're going to give rescue, and we're going to get those lungs open. So the first priority that we're going to look at would be asthma for wheezing. And then we rule out all the other stuff if it's not asthma. Now, asthma is an inflammatory disorder. There's usually something that triggers it. Could be cats, dogs, it could be grass, it could be food, could be anything. And what happens is they tighten up and it keeps air in, and then you see this prolonged expiratory phase trying to get air out. So remember, croup is inspiratory. Asthma is that prolonged expiratory. It gets trapped. And you can hear this when they breathe outwards, whether audibly or when you're listening to their lungs. And if you listen to their lungs, you're going to hear wheezing. And sometimes you hear nothing because they're that closed down. Now, how do we manage asthma in children? Well, once these children have cleared up from an asthma attack, they need to be tested. Their lungs need to be looked at to see how their function is, those pulmonary functions. As I said, it could be due to an allergen. So if it's due to an allergen, well, what is it? Is it the cat or is it the dog? Because if it's a bad asthma attack that keeps continuing, it's a bad thing, but you might have to get rid of a dog or a cat. You know, my husband went into status asthmaticus for 12 days straight in the ICU. And he was this close from intubated, but I didn't let them, and I could talk him down during these moments. And he could hear, I would hear in his lungs, on his right lower base, I'd hear a, and that's all I could hear in breath sounds. He tightened up so bad. Well, he's allergic to cats and dogs. So as much as I'd love a cat and a dog, guess what? I don't have cats and dogs in this house, and my daughter doesn't either. So try to protect him because he was horrible, horrible bad. It scared everybody. Now, those allergens, testing it, what they are, and then you see those little orange, pink, and blue things in the bottom. Well, we're trying to give a puff to a younger kid. It's hard to puff it and inhale at the same time. Put your lips around the little end of those little metered inhaler things, right? So these are called spacers. And you insert it on the blue, the pink, or the orange spot. Put it up around your mouth, squirt. What's the dose? 2, push 2, breathe in and out 4 or 5 times. Guess what? You got the dose. This works well. And if you have children with asthma and they're young, it's easier to do that than it is spending 15, 20 minutes on an aerosol 2, 3, 4 times a day. And it works just as effectively. Now, our goal is let these kids be kids. The kid's allergic to grass, though, he shouldn't be playing baseball and soccer, right? Maybe he should be tennis or swimming or bowling. So we can tailor a child's life around it. Or if we get them desensitized to allergens, then make sure that we have the proper rescue medicines and that they do prevent those exasperations by taking the medicines as they should. See, this little boy here knows already how to take his medicine in his little spacer. And if we do it like that and let them work with you, these kids, they tolerate this stuff well. Again, he's playing, isn't he? So we have rescue medicines, and then we have ones that prevent those type of attacks. Now, in pediatrics, we use something called Pulmicort. It's like Symbicort, Advair, Brio, one of those things that you see in the adult world. It's only given morning and night. Atrovent's another one. And it has a little bit of steroid in it, so it prevents asthma attacks. The other thing that we give is Singulair. And Singulair is like an antihistamine for asthma. It's like a Claritin, but it's for asthma, and it's given at night, and it helps prevent. And then the rescue is only when we're having problems. Now, if we're having an attack, if we are really short of breath, you know, status type of asthma, we're going to be giving corticosteroids IV, and we're going to be given, you know, the Atrovent aerosols also. And we might even go on and give the aminophylline. We might need to do supportive airway, et cetera, depending on the child. I mean, as much as possible, we try not to intubate those children because once they're intubated, it's hard to get them with that tube out. Okay, so we have gone over respiratory. You know, another thing I'll mention about children with respiratory is if you have children that are struggling to breathe and their O2 sats are low, you need to be able to choose what sort of equipment to use for those children. You know, I mentioned last week that infants do great with an oxy hood, right? That works, you can measure, it's accurate. Now, to put a toddler in that, it wouldn't work. You know, they're gonna bop that thing off, it ain't gonna work. But a little nasal cannula, O2 sats 90, nasal cannula works really well. So I would use that also. All right, let's keep going here. Now, you have a normal heart, and then you have a heart that there's congenital issues, and then you have the normal heart that during the lifetime, for some reason, a problem occurred. It could be due to infection, autoimmune. I mean, think about lupus. Doesn't it attack all organs? It could attack the heart, right? It could be environmental, and it could be something that your family handed down to you. So you're either born with it or you acquire it. Those are the two. All right, let's quickly go through a trace of blood through the heart, okay? So it comes in through the inferior or superior vena cava, and it goes to the right atrium. It goes through the tricuspid valve into the right ventricle. It goes up through the pulmonary artery into the lungs. It returns to the left atrium through the pulmonary veins. There's actually 4 of them, which I never understood, but there's 4 of them. Goes into the left atrium. It goes through the mitral valve into the left ventricle, up through the aorta, past the aortic arch, and down into the body. Okay? Tracing a drop of blood. You need to know where those valves are. Okay? Is it right-sided? Is it left-sided? Okay? Many conditions can occur. I'm going to give you a kink of a hose one right now. So we see this picture, how it comes, that red. It goes subclavian, whatnots to the upper head on the aorta, and it comes down and it goes to the body, right? Well, what after those 3 little vessels, there's a narrowing or a kink in the hose? Blood's trying to get down there, right? Now, what would you see on a newborn? Blood can't get down the aorta as much as it wants to, down to the lower extremities. What would you see? Decreased femoral pulses. I actually caught one in my very early career in the newborn ICU. It was an infant that came out, big boy, looked fine. I went to feel the pulses in the lower extremities, and I'm like, there is none. Then I got the Doppler, and I very, very faintly heard it. So this is something that's called coarctation of the aorta. So there's a kink in the hose. All right, now blood's trying to go down, it can't. So it's got to go somewhere. The heart keeps pumping. So it goes up those 3 vessels, up into the head. Okay, and we'll describe what that means as the kid gets older. But it goes back in that that left ventricle, and it stretches it, and it goes up into the left atrium, and it goes back into the lungs and fills it up. Now this kid is in congestive heart failure. Do you understand that backward kink? Because that lungs is a lot of place to fill up. Now, how do we treat it? Well, we just go surgically and we remove the kink. And the children actually do really well if caught at an earlier age. Now, what if the kid had a minor kink and we didn't catch it? Because you feel pulses. They're not that strong, but they're there. See those 3 vessels going up to the higher head? You are going to see this kid now complaining of headaches, and maybe even nosebleeds because of all that extra pressure going to the upper extremities, to the head and to the nose, and that's symptoms that you might see. Now, another thing with coarctation of the aorta, when you take a blood pressure at birth, and we usually will do when we see this 4 extremity blood pressures. Now, remember, I said there's no pulses going down. So those pulses with hardly there, you take a blood pressure on the lower legs, and it's going to be low, lower than the upper because the blood's going up. And the upper extremities are going to be about 20 millimeters of mercury higher. And that's the way as a nurse, you see it, the pulses aren't there. That's what I saw. I took 4 extremity blood pressures. I saw that the low extremities that's not getting blood is going to be decreased. And I saw the upper ones were full of a lot higher blood pressures, okay? So that's the coarctation of aorta. It's one of the things that you hear about, knowing that there's no pulses, knowing that the upper extremities blood pressures are higher and lower in the lower extremities, and that if it continues, you'll see nosebleeds and you'll see headaches as the kid gets older. Okay, now this is a little girl, I'm telling you, that was a coarctation of the aorta at 3 months old that they didn't catch and they didn't find it. They lived in an area that didn't have a really good cardiac center for them to understand, because, you know, cardiac is a difficult area in children, especially newborns. I know that I didn't know much until I started working in that unit. So what did I see? 3-month-old came over from the west coast of Florida. She came in with all of this. Poor feeding, because remember, she's not getting oxygen. Her lungs are filling up with fluid, okay? So she's not getting oxygenated the way she should. So now she's not eating well. And then her heart says, let me just try to beat a little faster to try to get oxygen around, breathing a little faster, trying to get oxygen. And of course, all of this extra expenditure of energy and then lack of oxygen leads to failure to thrive, which means she's not gaining weight at all or very minimally. And you feed her and she hardly tolerates it. She's not getting nutrition, so developmental delays. Now, this mother did have a history on her and a history of cardiac disease. So one of the care plans that we could write on this child is for the poor weight gain, inadequate oxygen perfusion leading to activity intolerance resulting in diminished energy to breastfeed. Therefore, poor weight gain. Okay, does that make sense to you? All right, you get a kid, you look at him. I mean, if you see him blue like this child up here to the right, oh, that's easy to see. Something's going on there. And many kids are red. You know, that could be Billy Rubin. That looks that red, you know, so you might see that with all that blue. But all that blue lasting, you know, more than a day, you know, something's going on there. Now, we can look at their height, their weight, and how they're eating, their color. Chest deformities, you can actually put your hand on the top of a child that has a big murmur, and you can feel the bzz, bzz, bzz after each heartbeat. You don't even have to put on your stethoscope to see that all, you know, right away. You're going to see those pulsations, as I said, respiratory problems, breathing wrong. And as they get older, just like old people, they will have clubbing of their fingers. That's not going to happen in the first year or two, but it will happen if it's one of those heart defects that never ever has a true real saturation of normal, like 95. Some children live in the high 80s, and that's just where they're going to be. So we're going to palpate, listen, chest, abdomen, pulses, heart rate, rhythm, and then heart sounds. When we suspect that there's going to be an issue or we hear a murmur, we're going to immediately, always an EKG is done, but an echocardiogram. And if the echocardiogram shows something prepare that family, that child's going to go for a cardiac catheterization. Now, the cardiac catheterization, we can do them for two different reasons. Well, if it's that newborn suspected heart something that had a positive, echo, we're going to do a cardiac catheterization for sure. That's going to be diagnostic. What exactly is going on in that heart? And the other thing we can do is, that interventional. Sometimes something's going on that we can fix. Nicholas Children's Hospital was one of those hospitals, first in the world on an older child, was able to fix a hole between the upper chambers of the heart with something called a helix device. And, if there's a hole, literally it was this flat saucer thing with a little thing, and it popped open on the other side. So there's these two saucer things that prevents blood from going back and forth. And it was called a helix device. They didn't need to do open heart surgery, and the kid will be just fine as they grow too. I think that's pretty neat. That's interventional. And then the third time is those electrophysiology studies. We use these for all age people. Usually when I see this used, it used to be on Wednesdays that we used to do our, we'll call them EP studies. Children would have a history of tachycardia for no reason. Their heart would speed up real quick and then slow down, speed up and slow down. And sometimes when it speeded up, these kids would pass out. So they were on medications to try to help them until we get them strong enough. And then this cardiac doctor, interventionalist is called, went in and zapped it and placed that little focus in that right atrium that was causing the heart to beat too fast, and would zap it. So now they'd wean off the medicine and the kid would not have to live on cardiac medicines for the rest of their life. Beta blockers, atenolol, right? Remember beta blockers from pharmacology, blocking those beats? Well, they'd be on high doses to keep those hearts from going too fast. So that's EP. Now, how do we take care of a cardiac cath? Well, it's pre-op, just like it is for any sort of surgery. Remember, young children, we don't hold them NPO for a long period of time at all. A newborn might be 2 hours only. And especially if they're breastfed, you're going to feed them 2 hours before the procedures because their dextrose levels will drop pretty quickly. So we don't want to do that. Now, the biggest concern is the consent's done, they went, you fed them up to when you're supposed to, and they come back. Now, they were placed on a table to do the cardiac cath. When they're done, they're placed back in their warmer or on their bed, and they're wheeled back into your room. Now, in the right groin, they have entered the femoral artery and the femoral vein. And quite a large catheter was put in there to be able to do the procedures or diagnostics or whatever they needed to do. When they're done, they pull it out and they apply pressure. Remember, it's a big hole they put in there. Can you imagine an infant with these two big holes? And if we don't occlude it long enough, or the scab pops off, or the dressing wasn't tight enough, they can bleed out in 2 minutes easy. That's how big these holes are. So, first thing you do when you get these children back from cardiac cath, check the dressing. It's a pressure dressing. Older children will have sandbags. Adults will have sandbags. But newborns, no, it's too much. They'll have a good pressure dressing on. Make sure it's not bleeding. And if it is, put your fingers, 2-finger breaths above it, closer. So if your leg is down and your heart's over here, you're going to put it closer to the heart, and we're going to push it down and of course call for help. But they're going to tell you just hold it until it's done and then reapply the pressure dressing. They might want to do a CBC depending on how much blood came out. Now, another thing, post-cath, you cannot bend the leg. So the right leg cannot be bent because it could break the clot off. So if I'm saying you can't bend the leg, they cannot get out of bed for 24 hours. They have to be in bed for 24 hours. Now, their pulses might be decreased because they had put these large catheters in there at first. So make sure you document what the pulses felt like, and that you, when you're trading off and shift report, let them know that it's decreased, but it's still a good pulse or capillary refill or whatever you see there. They can drink. You can put the head of the bed up slowly. You can't go from flat to high because, again, that could pop off the clot. So slowly lift the head up, and they can have things by mouth, or we can give them IV. And we're always going to check a blood glucose level. Sometimes these procedures go on for a while. Anesthesia doesn't use any glucose. And now these kids have Dex sticks of 20 and 30. So we need to replace that sugar as soon as we can. Or sometimes they use sugar and it's too high. So we need to know where we're starting out from. So cardiac cath, number one, check the dressing, because that's one of the biggest side effects or, warnings that we give parents. They could bleed from there. So make sure that we check the dressing, check the pulses and their vital signs, of course, as whatever the routine is. They can have something to drink, keep that leg straight, not on a pillow, straight, flat. And they're not getting out of bed. Check the blood glucose. Now, congenital heart disease, there's more of these than I ever thought, really. I didn't think there was this many. We know that one of the diagnoses, which you see a lot of congenital hearts, is your Down's children. Your 21, 13, 18, 15, 9, whatever the Down's is. And the most common type of congenital heart defect is a ventricular septal defect, which means a hole between the two ventricles. So let's get into some of these heart conditions. You don't need to know all of them, but I'm going to give you those things you need to know. Now, there's two types, acyanotic. That means you've got blood and oxygen exchanging, no problems. Then you have cyanotic. And now we have a lack of or no oxygen going to the body. So we have to get oxygen there somehow. And the one thing about holes, remember, it's going to go from low pressure, from the high pressure, it's going to go right into wherever low pressure is. Let me give you an example. You see this picture? Now, the right atrium is where blood comes back, is flowed all over the body, and it just gets back and it goes into the right atrium. There's not a lot of blood flow there, is there? Now, the left atrium has 4 pulmonary veins flowing blood in there. The pressure's high. So where's blood going to flow if there's a hole there, like in a atrial septal defect? It's going to go through the left atrium to the right atrium. And what's going to happen is the blood's going to go back into the lungs. So it's going to re-enter the pulmonary circuit. So you're literally putting it through the lungs again and again and again, because that hole is there. All right. So these atrial septal defects causes blood to go back into the lungs. So it overflows into the lungs. Okay, here's acyanotic, cyanotic. So atrial septal, ventricular septal, look, increased pulmonary blood flow, right? Because it's gone from the left side to the right where there's minimal flow. It just got back there from the whole body. It's hardly any pressure. It's lucky it's going back up to the lungs, right? And that left side is pumping. That's the left ventricle, poof, back to the right ventricle, up into the lungs, increased pulmonary blood flow. Now, the other thing I need you to understand is patent ductus arteriosus. And PDA is fetal circulation. This is a connection between your pulmonary artery, your lungs, and your aorta. Now, many diagnoses don't have any sort of oxygenation. And this little connection, this duct, this patent ductus arteriosus, will be the only way we can get oxygen to the body. So sometimes we need to keep that open. Now, intra utero, Mommy produces a hormone called prostaglandins. And that prostaglandin hormone is what keeps that duct open when you're pregnant. After birth, it can close immediately, or they say up to 21 days later, but it's usually within a day or two, you're going to see it close. Now, if you were a transposition of the great arteries, which means you have your aorta where your lungs should be, and you have your lungs where your aorta is, you're going to have blood flowing, and they're not connecting, and your body's getting no oxygen. The only way to get oxygen to that infant is keeping that patent ductus arteriosus open. And that's what we do, and it works great. You know, you're thinking this kid is like, oh my God, must be sick. These kids, we actually wait for about 7 days to do surgery. We bottle feed these children. Parents hold their children before surgery, and then we send them to surgery. Now, sometimes because the patent ductus don't work too much, sometimes we gotta open up that patent foraminal valley. Remember at birth, there's that little connection on the atrial septum. It's called a patent foraminal valley. Sometimes we have to open that a little more, and we do a cardiac cath and we make that hole bigger. So we punch a hole, open it up, and that helps with it. And we also, start to patent the prostaglandins on this child. And these are some things that gives us that time that we can help this child. Now, obstruction of blood flow from the ventricles. Well, I have mentioned coarctation of the aorta. It doesn't go all the way through. It comes back to the left ventricle and goes back into the lungs. That's your obstruction. Well, any valve that's stenosed, stenosis is a narrowing. That means blood still can go through there a little bit, but it's called a stenosis. There's another word called atresia. A means without. That means there is no connection, okay? So stenosis, still a little blood flow goes, but not the way it should. And that's aortical pulmonic, and we can see it. They go to cardiac cath, we do a balloon, and we open them most of the time. I mean, it's a dangerous procedure, but most of the time they do really well. Now, decreased pulmonary blood flow. The most common diagnosis you will see on HESI, exams, and your NCLEX is tetralogy of Fallot. Tetralogy of Fallot is very simply like a pulmonary stenosis. So everything is okay. There's certain things with tetralogy that you'll see. Now, when that body forms the heart with tetralogy of Fallot, usually the pulmonary arteries open, less blood flow to the oxygen to the lungs, and oxygen's going around and everything's great. And all of a sudden, there's a flap of skin that covers the pulmonary artery, and now there is no blood flow to the lungs. This child will go from an O2 sat of 100 to 0. Actually, I saw 100 to 10. It was about 5, maybe 10 seconds. The kid went from white to blue-black. What did I do? And this is what you do in case you have a tetralogy spell or a blue spell. You take the knees and you put it to chest right away. It's called a knee chest. What does it do? You have pressure in your abdominal cavity and your thoracic cavity. When you push that knee chest, it changes pressure, and that piece of skin comes off that pulmonary artery, and now blood flows. So it is scary. It happened to me one night at 4 o'clock in the morning, and that kid turned colors, and it was scary. I'll never forget him. His name was Dylan, okay? That's how well I remember that little boy. All right, and tricuspid atresia. Well, where's the tricuspid valve? It's between the right atrium and the right ventricle. There's no valve, nothing, which means blood's not going to the lungs. So how are we going to get oxygen to this infant? keeping that patent ductus arteriosus open, we're going to give a slow, continuous administration of prostaglandins. It's a slow, continuous drip of medicines, and it works really well until we can do other surgeries. Now, I've mentioned to you transposition is just a switch. Our goal here, we know, is to keep that oxygenation going by that PDA, and that literally, the name of the surgery is called arterial switch. They pick the two vessels up, turn it around, and put it back on, just like that. It's a big surgery, but the kids actually do well, and long-term outcomes are great. They really are. You know, like 2 years ago, or it's more than that now, 3 years ago, a student came in and said to me, "You were my nurse when my son was in the cardiac ICU. He had transposition. And it's because of you, I wanted to go be an RN and take care of these kids." Oh my God, that just blew my mind. You know, that you do make such an impression. And this kid had just graduated from college. So that made me feel really good, you know, that, you know, you care for a child, has this diagnosis, and his outcome was so great. And the last one I'm going to mention is the most sad, I would say, the most difficult, severe of all congenital heart defects is hypoplastic left heart syndrome. This means the left ventricle muscle doesn't work. It's small, it's floppy, and blood just doesn't go around. And it's going to end up with 3-stage surgeries. Many of these children end up with a transplant, but I've seen them live to be 30 with it. But it is a lot of care, a lot of hospitalizations to get there. Any questions about any of that? That's the really intense stuff. Okay, let's go over this again. PDA. This is there at birth. It connects pulmonary artery and the aorta. We call it PDA. It's just easier to say that. You can hear it. It's like a washing machine type of murmur. You can hear it. It's not, you hear, you can hear these murmurs, okay? Now, the other way you can see it, now most congenital heart defects are going to be on monitors, have arterial lines, because they're going to need these to go to surgery. And that arterial line is going to have this, what we call a wide pulse pressure. Now, at birth, an infant's normal blood pressure is 60/40. But look what number this kid with an open, wide open PDA, 60/18. Now, what if we don't need that PDA and now we need to close it and it's not closing by itself? How would we know that happened? Well, there's medicines we'll give, but you'll see that pulse pressure go back to normal and that murmur will go away. Pretty neat. And I used to listen for that stuff. So again, sometimes we need to use a PDA. Most of the times it will close. And sometimes we're going to need that continuous infusion of prostaglandin. What is the purpose of prostaglandins? To keep that open? Well, we know it's for oxygen, number one, but it also maintains cardiac output. Very important concept. Maintains cardiac output and oxygen saturation levels, okay? Now, if you have a PDA, and many premature infants is where I see it a lot, PDA's there and it doesn't close. And now you're just keep, you know, this lungs washing out with extra oxygenation, et cetera, which again, that could be a problem. So we close it. And we do it by a medicine. And it's an NSAID. It's indomethacin. You can use these for back pain. Indocin, it's like an ibuprofen IV, literally. And whatever way, it blocks the prostaglandin in that duct, the patent ductus arteriosus, and it closes. And we usually give 3 doses IV. And again, how do you know it closed? The murmur closes, you don't hear it, and the pulse pressure becomes normal. Now, there's a couple of things here with all the way things go, and I left them here for you to look at. but I've literally explained it to you. But there's pictures to show you blood flow, etc. Okay, now you've got the kid who's coarctation and now is in congestive heart failure, right? All the fluids got up into the lungs. The heart's not working right, and now we got fluid in the lungs. How are we going to take care of this kid? Well, we know they're going to be tachypneic, tachycardic. Maybe they're going to be a little hypoxic. And of course, those x-rays are going to show fluid everywhere. Our goal, we're going to improve that cardiac function. You know, we give digoxin to these children. You know, one of the things, you know, this has been asked many times, you just gave the kids some digoxin and they vomited up all of it. What do you do? What do you tell a parent at home to do? Well, you're going to tell the parent, you're going to do nothing. You're going to give the next dose when it's ordered. You're not going to double dose these children, okay? Very important thing. So if your kid vomits the digoxin, and they're home, this is part of your teaching, you're going to tell them, do not repeat it, okay? Because it can become toxic. Wait till the next dose is due. Usually it's every 12 hours. We're also going to be giving something to get rid of the fluid. We're going to give a diuretic, you know, furosemide, Lasix. We're going to give this 1 milligram per kilogram is what we give. And we use it with children really well. And we're going to make sure that, you know, they get rid of the fluid. Because you get rid of the fluid, you help digoxin, help that heart beat slower, more effectively. Your oxygen is going to get better and your heart's not going to work as well. So how do we know this is going on? Well, we know that if we're watching daily weights, which we do in the hospital, if they have all this fluid, we're going to watch those weights go down. So we know that they're losing fluids. So let's say we're giving digoxin. You're going to, just like you're taught in pharmacology, count an apical pulse for 1 minute. You're going to check your electrolytes because your potassium must be normal. If you have a digoxin level, check it. Again, vomiting might be the only sign that they're toxic. If it happened right after one med, probably not. But if you see them vomiting again, you would teach parents to, you know, tell the doctor. They'll probably want the level. In the hospital, you'll tell the doctor and get another dig level. And we're just going to make sure that this kid is not breathing so hard, the heart rate comes down, that they're able to maintain their nutritional status. Now, a child in congestive heart failure is so weak, you may have to tube feed these children. That's one of the things that you might have to do for them, because these children have no energy. You know, sometimes you give small, more frequent meals to give them that rest periods. You know, that can help too. They do need their nutrition. They do need the proper type of calories, okay? But these children do better if they're small, frequent, or if we tube feed them. Give them a time to lose that extra fluid so we're not overtiring them at all. Because if they're congestive failure, they got a weak heart. Here's a nice picture of clubbing. I mean, you'll see those in those kids that are 8 or 10 years old with hypoplastic left heart syndrome. Their O2 sats are never normal, okay? Now, let me explain one thing about this group of children. You know, when you do not have a normal O2 saturation, your body is a neat organ. It says, you know something? Let me produce more red blood cells. And it produces more red blood cells because what do red blood cells do? They carry oxygen, but there's no more oxygen because O2 sats might be only 85 on some levels of this child's life. So it produces more red blood cells. So they become polycythemic, which means their hemoglobin hematocrit could be 18 and 54. Not 14 and 52. Their hemoglobin hematocrit is really high, really thick, dark red blood. So as a nurse, you're going to help these parents, you're going to educate them, you're teaching from the moment they walk in the door, have them ready, prepared for what's going to go on. I'll ask them, would you like to see a child who just had surgery, from the doorway? And if there's a parent in that room, do you mind if I show your child that he's going tomorrow? Let me tell you, the cardiac family works together and they will allow it, but just make sure you're not doing any wrong things with HIPAA. But sometimes they need to see that to be prepared. Again, cardiac cath, I've already gone into it. Make sure that we look for bleeding, make sure you check for pulses, bed rest, elevate that head slowly, and they can have oral or IV fluids. And again, of course, check blood glucoses. Bacterial endocarditis, again, this is going to have that prophylaxis before any procedures like dental or anything, just like adults, same thing, which goes on. Rheumatic fever is something that happens because we didn't completely treat a strep throat. How many times you get a sore throat and ignore it and don't get antibiotics? Well, this could hurt a kid. Or you have two kids at home with a sore throat. All right, let's split up the antibiotics between them. I mean, it happens in some families. They can't afford 2 antibiotics for these kids. It happens. But first question I'm going to ask when I suspect rheumatic fever is, has your kid been sick lately? And if they say a sore throat within the last 2 months, it's probably rheumatic fever. What do you see? You're going to see a rash. You're going to see joints, polyarthritis. You're going to see this weird wobbly gait on them. And the big thing is permanent valve damage. Now, we can treat everything, but we cannot treat the valve damage. Once it's damaged, it's damaged. But we'll give them long-term antibiotics, and that will clear up even that weird walk, that Korea stumbling sort of thing, those nodules, etc. So rheumatic fever is because of strep throat. They can have high cholesterols, something we didn't look at years ago, we do now. They can have all sorts of dysrhythmias. I've seen a pacemaker in a child less than 2 years old with Brady dysrhythmias. The only thing with that is, those pacer wires are going to get short. They're going to have to be replaced frequently as they get bigger. And as I said, tachydysrhythmias, most likely medications and maybe an EP studies, electrophysiology studies to zap whatever's causing that. Pulmonary arterial hypertension. You have a child, some way the lungs got damaged and it doesn't allow oxygen and carbon dioxide to exchange. And they tighten up and they say, no, I'm not going to. Well, it causes that child, they have absolutely no reserve of oxygen. So they're going to be dyspneic and even sometimes just walking, from class to class. Chest pain because of that tightness. And of course, dizzy, lack of oxygen. Cardiomyopathy could be due to sometimes a virus, could be familiar. And his heart gets big and floppy and it just doesn't work the way it should. And it usually ends up with a transplantation. Now, the biggest complication of a heart transplant is rejection. Valentine's Day is coming up soon. My little guy is going to be on, I think it's year number 10 post-transplant. And my little guy, I took care of hypoplastic left heart. I took care of him during the first stage, second stage surgery, and he ended up, his heart just wouldn't work anymore. And he ended up having to go and have a transplant. He's 10 years post-transplant, and every Valentine's Day I think of him, and he's actually doing well. Now, every kid that gets open heart surgery gets a chest tube. Now, they need to come out. I don't know if you've ever had anybody who's ever had a chest tube removed as an adult, but I've asked the adults because I do adult and I do children's medicine. I'm a weird person. Not many nurses do it, but I did, and I'm really glad I did. They say it burns intensely, but it goes away. So it's like really bad, and then it goes. Make sure you medicate this child before a chest removal. priority. Number two, let them know it will hurt a little bit. Be honest, be very honest with this. And again, get on their developmental level. Head of the bed should be elevated, medicate, and of course, vital signs before and after you've given pain medicine. So chest tubes do burn, and we take them out when they stop draining. And we have found out young kids do have high blood pressure, so we're monitoring them at earlier ages. Kawasaki is a vascularitis or an inflammation of vessels, and the ones that we're concerned about is coronary arteries. They'll get an aneurysm in it and could burst. And if you have an aneurysm on your coronary artery that bursts, most likely you're going to die. So what do you see? You see a kid who's got a fever, you've got a rash, all of a sudden his hands of his soles of his feet and palms of his hands will start peeling, strawberry tongue. You'll see these glow in the dark red eyeballs. I mean, they're very distinctive. And of course, these cracked lips. And this child, the first thing we really need to do is check an echocardiogram, making sure those coronary arteries are okay. And treatment. Only time you ever give aspirin to a child is Kawasaki disease because it prevents clots. It's used like an anticoagulant. And we give intravenous immunoglobulins, and it's like a month treatment. And usually you get it once, you're not going to get it again. But it is a very serious disease, but it's the only one we ever give aspirin to, and the IVIG. Shock is usually septic shock, like I said earlier, and then we'll just treat it symptomatically. So here we go, a PDA question. So surgical closure of the patent ductus arteriosus would do what? Well, what does it connect? So what it would do?
Steve?
It stops the loss, let me see. It prevents the return of oxygenated blood to the lungs. Because the aorta pumping out, it puts it back into the lungs. So you don't want to overflow your lungs. Remember, it connects the pulmonary artery to the aorta, okay? Intense stuff today. You're going to have to listen to that again. It's a lot of information there, but I think I explained it as clearly as I can. All right, let's go ahead and let's do your Kahoots for today. And then we got a quiz to go afterwards. And I think we covered what you need to know for that quiz also. I was making sure as we went on. All right, let's get going. Week 5 already, guys. Respiratory cardiac. A majority of upper respiratory infections are caused by what? This is viruses. Remember, upper respiratories, they'll always tell you Tylenol, Motrin, and they're not going to treat you. And usually it will go away, the fevers, within 3 days. It's usually not your bacterias at all then. You walk into a 6-year-old child's room and you find them not breathing and does not wake up. What do? What does your CPR tell you to do, right? immediately chest compressions and yell for help, right? Because chest, they say you have enough oxygen, you just get those chest goings and you could save the child. Call code rescue. A multi-select. What are some signs and symptoms that smaller children may exhibit that has a respiratory infection? Everything: fever, vomiting, poor appetite, abdominal pain. Get that fever down and you're going to see a different child. It's quite amazing. Another multi-select. What do you look for when assessing respiratory function? We just want to see how they're breathing, right? And all of those things relate. Good. What would you look for after a child has a tonsillectomy? So the thing with tonsillectomies, we're worried about those scabs that break off. And if a kid is swallowing, it's probably bleeding. So swallowing more than normal, this is probably this kid is bleeding, and that's a danger sign. Another multi-select. Nursing care for a child status post tonsillectomy include? You're going to give them pain medicine as ordered, okay? Don't let it go too far, then it won't work. Gum for your older children. It helps with those ear, and it's really bad pain. And of course, an ice bag. Another multi-select. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? The reason why I did it this way is tracheobronchitis and bronchitis is the same thing. It's a different word for it. But that dry, bothersome cough is bronchitis or tracheobronchitis. Those are the ones that are going to need some cough medicine because it is bothersome. What signs and symptoms would you see in a child with otitis media? What is an otitis media? Ear pain is number one. Sometimes you would see them with a lot of, secretions coming out of the ear, loss of appetite. Not always do you have a fever with the ear infection. It's the pain more than anything. The monthly immunization for RSV is? It's given through late fall to early spring. And again, it's monthly for those immunosuppressed. We don't want them with all those mucus. And it's called Synagist. All of the following are signs of early respiratory distress in children, except You're going to see tachypnea, tachycardia, diaphoresis, restless. If they are bradycardic, be ready to code that child. That child is just about to go on you. A 4-year-old child's been taking the meds for asthma and they're still wheezing. What information is important? What do you need to know? So they're giving a 4-year-old, doesn't have a spacer, they're not getting the medicine. That would be very important information to know. So teach them how to use a spacer. An 8-year-old with croup exhibits what signs and symptoms of respiratory distress? So an 8-month-old, you're going to see the substernal retractions, they're going to be restless. Respiratory rate of 25 is actually low. And if they are respiratory distressed, their heart rate's going to be 120, 130. That pulse is fine. And abdominal breathing, that heart rate, again, is too low. And they do have abdominal breathing. Signs and symptoms of asthma include all except again, it's prolonged expiratory phase. They're trying to get the air out. They can get it in, but they have to force it out. And they will have an initial hacking cough. That's part of asthma. Signs and symptoms of congenital heart disease include all except weight gain appropriate? No, they're burning so many calories, they can't eat well, it's going to be low. What should you not do to children diagnosed with croup and epiglottitis? They have an inflammation of their upper oral pharynx. What aren't you going to do? So you're not going to look in there because unless you're the person who can intubate, you can create some more swelling. So never do that. The epiglottis is what? Leaf-like structure prevents choking and it covers the larynx when you're swallowing and eating. Treatment for infectious mononucleosis. It's a virus, so no antibiotics. Absolutely no contact sports. And really the only treatment would be the antipyretics and liquids and rest. That's treatment, but no contact sports. You don't want anything to happen there. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important for you to gather? Well, we want to know when they've had medicine and their temperatures, but immunization status is very important. Are they immunized or is this pertussis or something else? APGAR scores at birth really don't matter at this point. What is cystic fibrosis? So cystic fibrosis is lungs and the digestive tract, small intestines, where the lungs don't work well and you're not absorbing the nutrients you need from the food you're eating. What is the greatest risk for an infant having a cardiac catheterization? Again, hemorrhage. Remember, it's a big hole in a big vessel and they could bleed out very quickly. Always check that first. How is cystic fibrosis identified? Remember, you can lick a child with cystic fibrosis and taste the salt, right? So it is sweat test on these children. I'll multi-select. What is included in the plan of care for a child with cystic fibrosis? So it's twofold. It's going to be aggressive physical therapy on your chest, having those enzymes to break down the nutrients, high protein, very important. And they're losing salt like crazy. So it's actually a high sodium diet. It is not low. What is a drug of choice for the pharmacologic closure of a PDA? And that is your indomethacin. Prostaglandins is what's needed to keep it open. Indomethacin says prostaglandins go away and it closes it. What is not a feature of tetralogy of Fallot? Now, tetralogy of Fallot is on the right side of the heart. So if you look at that, what is not on the right side? And what's not on the right side is the aortic valve, right? Now, there is a hole between the chambers. There is that pulmonary stenosis, and the aorta sort of rides over. And the other thing that can happen is that right ventricle can get stretched out when the blood can't go up. So it's 4 things that are part of tetralogy of Fallot. What medication would you hold for an infant that is vomiting? Vital signs are 98, 88, 32. Like, which one of those vital signs isn't right? And that's going to be digoxin. Usually the physician will say heart rate below 100, hold the digoxin and give me a call. And it could be they want to do a drug level. Why would a child with tetralogy of Fallot not gain weight at the normal rate? If they're not getting oxygen, they have no energy, They can't eat, they're not going to gain weight. No food, no weight. All examples of cyanotic heart murmurs except which one? Which one doesn't get blood to the lungs? That's how you read this one. So aortic stenosis is, there is no problem with that. So that would be your answer there. What is the most common cyanotic congenital heart defect? Common now. It's the one that's on every test. And that's going to be tetralogy of Fallot. You know, remember that it does flap, it stops blood from going to the lungs. It is cyanotic. This is the one, I'm telling you, they love to pick on this diagnosis. I've had every nurse come back to me and say, yep, it was on the NCLEX. Nursing care following a cardiac catheterization. You are going to, number one, assess that for any blood or even a big ecchymotic area. The rest, no, you're not going to do. Elevate it, no. Ambulate it, no. And then raise the bed to 45. You're going to go slowly, maybe not up that high. A multi-select. Nursing education for the cardiac catheterization include all except. Again, we're not going to ambulate and we're not going to bend that extremity. Very good. Which information is most important when rheumatic fever is suspected? What did I tell you caused rheumatic fever? And the biggest concern is permanent valve damage, and it's usually the mitral valve. So it's that sore throat, it's that pharyngitis. That means you had strep, it wasn't treated. So we can treat it by long-term antibiotics. Signs of shock in children include all the following except shock. What do you see? You see hypotension, tachycardia, altered mental status, poor capillary refill, decreased urine output, hypotension. Which of the following best describes the pathophysiology of Kawasaki disease? Remember, this is where we worry about the veins in the heart, the coronary arteries. And it's an inflammation in the vessels, which causes a rupture, could cause problems. How do we treat that, right? A multi-select. A clinical manifestation of Kawasaki is the director of the cardiac ICU, the medical guy, his son at 3 years old came in with Kawasaki. And his eyes, well, I'm telling you, they were that glow in the dark. So The erythema marginum, usually it's more of a petechiae type of rash, but the rest of it, yes. So what is the treatment? How do we treat Kawasaki? It's aspirin and IVIG. Only time you give aspirin, and the aspirin is to prevent clots. It thins the blood. Which of the following is the most common cause of shock in infant and children? And it's infection, sepsis. That's the one that causes it the most out of all of them. What are the defects associated with the tetralogy of Fallot? So it's the stenosis on the pulmonary artery. It's the hole between the ventricles. The aorta's over and the right ventricle gets stressed. If you look at the other one, you have left-sided stuff. And then the switch is transposition. It's nothing to do with tetralogy. The young child with tetralogy of Fallot may assume which position naturally when having a tet spell. I mean, if an infant, we're going to do it for them. And they squat. It does the same thing as knee chest on the infant. Transposition of the great arteries is what? I tell you, they do surgery by doing a switch. They turn them around and put them back on. And that's the pulmonary artery and the aorta. They're switched. So we need to change them. This is the one that will need prostaglandins to live, to get oxygen. Which of the following is not an intervention indicated for transposition? Anything oral is not going to work on this child. So the prostaglandins, keep that PDA open, do the switch operation, and put that hole where that patent foramen is to allow some more blood flow. A multi. Why is prostaglandins given to a child with transposition of the great arteries? Why do you give it to anyone? Oxygen, cardiac output has nothing to do, it's not an antibiotic, has nothing to do with infections. What's the purpose of giving indomethacin to a neonate with a PDA? So the PDA is kept open by prostaglandins. The indomethacin says stop, no more, and it closes, and you don't have to do surgery. Where is the PDA? What does it connect? It connects the aorta to the pulmonary artery. So blood going to the body and the lungs can give it oxygen. This heart defect allows blood to pass from the left ventricle to the right ventricle. And it's a septal defect, and it's between ventricles, so it's ventricular septal defect, or a VSD. A multi-select. What is a sign of digitoxicity in infants? Toxicity. And you remember, infants can't tell you things. All they can do is show you. You might see what? You might see them retching, vomiting, or their heart rate's too low. Yellow spots, that's an adult. They can't tell you they have them. What is congestive heart failure? It just means the heart is very weak. And then you see all the fluid build up into the lungs. And then you see a kid who's tachypneic, tachycardic, retracting, can't eat, losing weight. Left-sided congestive heart failure causes what? The coarctation does this. Fluid in the lungs, shortness of breath and coughing. Yes, very good. After a heart transplant, what's the leading reason children die? Thomas is going to be 18 years old this year. And it's rejection, okay? Rejection is why. I'll multi-select. Signs and symptoms of rheumatic fever include. So if you see those things, you're going to say, so has your kid been sick recently? And they're going to say, well, the kid has sore throat, right? And remember, all of these could be cleared up with treatment, except for a valve. They're permanent. I'll multi-select. A child's about to have a chest tube removed. What should you do? You're going to give them something for pain. You're going to monitor vital signs. You're going to tell them on their level what's going to happen. And don't lie. Tell them it's going to hurt a little, because it will. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What's your priority? To get them coughing. Medicate them for pain. And then they'll do, instead of spirometry, get out of bed, change their position, and everything you need. Medicate for pain. They just had surgery. Their tummy hurts. An infant, 3 months, the fever 103.6. What would you medicate the infant with? If a parent ever tells you aspirin, you tell them no, that's only for what? Kawasaki disease. So younger than 6 months old, only acetaminophen. After 6 months old, you can add the ibuprofen. A newborn infant is assessed. The nurse finds very weak lower extremities. What should she assess next? Let's do a 4-extremity blood pressure. Let's see if the lower ones are lower and the upper ones are 20 millimeters of mercury higher. We know then it's coarctation. Let's tell the doctor what we found. A multi. A critically ill child's on complete bed rest. What can a nurse do to prevent complications? No, we don't think kids are going to be, on bed rest long times. I mean, you have some kids that are in the hospital for months, and they do get pressure sores, and they do get pneumonias and all of that, blood clots. So you are going to, use whatever you can. Keep them dry instead of spirometry. I use pillows, blankets, I use toys, stuffed animals, all of these things. Elevate the head of the bed, maybe, maybe not, depending on the patient condition. But the other stuff, absolutely. How can oxygen be delivered that's easiest, tolerated, and accurately monitored for infants? If the kid is older, toddler, you're going to put on something else. But infants, this is the best way. And we're going to put them in that clear plastic oxy hood. In the toddlers, maybe that nasal cannula. That's easier for them. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, their lungs are full of mucus. They're clogged. We're going to do deep breathing, chest PT exercise, and we're not going to ambulate PRN. We're going to ambulate every 4 hours. We're not just going to say whenever you want to. They need to be up and moving. And a multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? So those are all the answers. Those are your questions on your NCLEX, so you're going to get that question right. What is a cardiac defect where there's no valve between the right atrium and the right ventricle? Remember the words I taught you, right? We have stenosis and we have A. And what is the valve name between the right atrium and the right ventricle? It's called a tricuspid valve. Without, no valve is A, atresia. Tricuspid atresia. And last question. When an infant is breathing fast, tires easily, needs rest periods during feeding, what should you assess? What do you think is going on here? Probably something going on, congestive heart failure, right? All right, good job, guys. Let's see how we did, and then we're going to take our quiz. Mia, good job. It was a hard one. JP, and number 1. Lisa, good job, Lisa. Dilla and Wendy. All right, what I want you to do is go to your modules. I want you to go to quiz 3. And you have 15 minutes to do it. When you are done, you may leave. Any questions? Anybody need any help with this? Just let me know, okay? Because I know this is a difficult topics.